Hello, everyone, and welcome to the June issue of DermSurgery Digest. I'm Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. We continue with our updated format, separating the surgical oncology and reconstruction portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Rapid Pearls, will briefly cover the clinical application of the data from each article not covered in our Spotlight episode. Our goal with this format change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for this episode are Tara Jennings with Cooper University Hospital, who will be providing the article summaries, with Brad Merritt, Associate Professor of Dermatology at UNC Chapel Hill, providing the expert commentary. Thank you for listening. We hope you continue to enjoy this new format, and as always, have a happy surgery day.
Welcome to this month's DermSurgery Digest podcast. My name is Tara Jennings, and I'm a Mohs surgeon at Cooper University Hospital in New Jersey. This month's featured expert is Dr. Bradley Merritt, who is professor and director of Mohs surgery and cutaneous oncology at UNC Chapel Hill, and this is our Rapid Pearls episode.
Thank you for having me. Appreciate it.
So we'll start out with our first article, which is Factors Affecting Time to Surgery in Patients with Extramammary Paget's Disease in the United States by first author Tejas Joshi and senior author Deborah McFarlane. So extramammary Paget's disease is a rare cutaneous malignancy that often requires complex surgical planning. And in this study, the authors used a SEER database to evaluate factors associated with delays in time to definitive surgery among about 1,600 patients. They found that female patients had significantly longer times to surgery compared with male patients, potentially due to more complex anatomy, increased use of multidisciplinary surgery, and lower rates of Mohs surgery. Unmarried patients were also more likely to experience delays greater than 90 days, highlighting the impact of social factors on timely cancer care. So, Dr. Merritt, what did you think of this article, and what did you kind of take away from it?
I think it's a great effort to look at disparities and why people don't get treated soon enough or appropriately with EMPD.
Yeah.
And I think the more important question to draw also that, we've looked at is time to diagnosis of EMPD and how long, 2 years, 5 years that it takes. I think the delay probably does not affect treatment outcome of these patients, like 2 to 3 months. But
Yeah.
I think the biggest takeaway for me on this paper is like disappointing to see yet another disparity where women's health seems to suffer, and like the treatment of we see a lot more patients from urology for men with EMPD than I do women, and that's definitely held true in the 15 16 years I've been at UNC. It's just like a huge discrepancy and disparity.
Yeah, absolutely. I mean, I think that by the time I see women, they've been bounced around to probably like 3 or 4 different doctors before even seeing me. But at your institution, or do you find that the people that you work with are kind of sending directly, or the dermatologists surrounding sending directly to you immediately?
If the dermatologists catch the diagnosis, patients come to us.
That's great.
If not, it's the third time they've been treated, then they come to us with like multiple scars and disease discontiguous and broken up, and the cure is going to be very difficult.
Yeah, no, definitely. All right, we'll move on to our next one, Pediatric Ingrown Toenails, a Practical Treatment Algorithm by first author Adriana Matter and senior author Matilda Irizo. So this review article proposes an age and severity-based approach to managing pediatric ingrown toenails. The authors highlight that although ingrown toenails are common in children and adolescents, management often varies widely because of concerns of patient cooperation, anesthesia, and long-term nail outcomes. This paper uses the Hypfide staging system. Stage 1 involves pain, erythema, and swelling. Stage 2 adds granulation tissue and drainage, and stage 3 includes chronic hypertrophic tissue overgrowth. Conservative approaches such as taping, cotton pledgets, and nail bracing remain reasonable for mild disease, while taping show particularly favorable outcomes. However, recurrence rates for conservative therapy ranged from roughly 5 to 23%, and moderate to severe cases often ultimately required surgery. A major practical point from this paper is that age changes management. In children younger than 10 years, the authors recommended avoiding procedures that permanently narrow the nail plate, such as chemical matrixectomy, because of concerns for future nail dystrophy. Instead, they favor procedures targeting hypertrophic soft tissue alone. And in older children, adolescents, chemical matrixectomy combined with removal of granulation or hypertrophic tissue demonstrated better long-term success. All right, what is your takeaway and thoughts on this one?
I mean, I think the biggest thing for us, for me as a surgeon, is just seeing the three really cool procedures that they shared about how to remove, lateral, overgrown nail fold, distal, kind of the hyponychium, and then that U-shaped super U, I think, or whatever whatever the title is, to not be afraid to remove that overgrowing skin. And the cures and the clinical photos look fantastic. So I think imagining that as a pretty straightforward procedure to do, I think could be really helpful for us. Many of us are not going to be seeing pediatric patients, but if it ever comes up in our adult patients, or if you're having some problems with healing, maybe after like treating squamous cell or melanoma or something of the nail unit, could be something to consider.
Yeah, that's exactly what I was thinking too. I thought that it was really helpful just to kind of, we haven't had a review article like this, I feel like, where you can learn these techniques. So I thought it was really nice. Okay. Our next one is Zeroed In, Improving Histologic Tumor Tracking During Mohs Surgery by first author Ryan Welter and senior author Ali Khan Samani. So Mohs surgery relies on precise histologic interpretation, but tissue dropout and minimal residual tumor can make margin assessment challenging. In this article, the authors describe a simple slide marking technique to improve tumor tracking during Mohs surgery. By identifying residual tumor on superficial sections, marking the area directly on the slide, and overlaying deeper margin sections, surgeons can more accurately determine whether tumor persists at the true surgical margin. This practical zeroed-in technique may help Mohs surgeons improve histologic accuracy, reduce unnecessary additional stages, and maintain the high cure rates expected with Mohs surgery. The greatest benefit would likely be in complex situations such as large defects, multiple tissue pieces, difficult orientations, and recurrent tumors. I thought that this was really interesting thought to do this. What was your kind of takeaway and thoughts about this one?
Yeah, I mean, I learned this trick from Dave Brodlin in 2009 and 10, and I love it. I use it all the time. My one pearl is like, be careful because you're like laying the slides on top of each other.
Yeah.
Make sure they're dry. Make sure
Yeah,
that
they stick to each other. Just thinking that.
they stick to each other, and it's like, oh no, and then the histotechs get kind of grumpy about messing up their slides. It's super helpful. I think the number of things. I think the other pearl from this paper is have your techs get those early sections.
Yeah.
The other pearl I'll add to that is if you're thinking of running immunos on like perineural squam or something, or after the fact, and you're like, oh, let's run immunos because we don't know, save those early cuts and don't stain them. Because if you don't save them and you cut back into the block, of course, you're going to get more likely to have positive tumors. So I love this technique. I think another one that I use is take the slide in the room with you and carefully lay it over you have to account for like tissue shrinking and everything when you clear it out. But it gives you at least an idea of a really closer, refined area to hone in on.
Yeah. Practically speaking, does it take a lot of time for you, like extra time for you to do this, or not really? It's just a couple more.
Oh, not at all. I mean, compared to going back in and the cost of an extra, another 17312 or 17314, and the lab time, like, yes, for sure, it's worth the extra 2 minutes that it might take.
Yeah. Okay.
I love this technique. It's great for them to share this in a manuscript format.
Yeah, I really like it too. And they have a great schematic too, and they're like exactly how they do it. So I encourage the readers to really go and look specifically at this one because it teaches you exactly how to do it. All right. Our next one is Migratory Squamous Atypia After Mohs Surgery by Wilson Omisset and senior author Mark Russell. So eruptive squamous atypia is a rare phenomenon where reactive squamous proliferations can develop after surgery or trauma, often mimicking recurrent squamous cell carcinoma. In this case report, the authors describe a patient who developed migratory squamous atypia after Mohs surgery for a well-differentiated squame, followed by a similar lesion after minor trauma on the opposite hand. The lesions demonstrated a Kebner-like response and ultimately resolved with non-surgical therapies, including intralesional treatments. The authors highlight that additional surgery may worsen the process by creating further trauma. I think that my overall takeaway is that new keratotic lesions after Mohs surgeries are not always true recurrence, and recognizing eruptive squamous atypia may help avoid unnecessary surgery and guide treatment towards less invasive options. I know that I've run into this a lot. What are your thoughts on it?
Same, and it's almost always the extremities,
Mhm.
hands, legs. Yeah, forearms less commonly for me at least.
Yeah.
Yeah, some form of eruptive KAs or yeah, Kevin Rise. Yeah, trauma causing path. Some process that yeah, I think we should be really careful about going back and cutting out a second or third time.
Yeah,
Some of them
definitely.
you just write it out and just like the old history of KAs, they'll resolve on their own. The challenge is knowing when that's the case and when it's actually a recurrence. So
Yeah.
close follow up, I think, is the biggest pearl in these if you're going to treat with something intralesional or steroids or five fluorouracil or methotrexate, things like that. Just close follow up.
Yeah, definitely. I think that I tend to go towards a mix of ILK40 and FUDEX intralesional, but I'm curious why it happens specifically on the extremities. Maybe that's something that someone could figure out for us. But I've noticed it particularly in elderly women's legs. It's just like
Mm-hmm.
it just
Mm-hmm.
happens, and I often get sent these cases for Mohs actually, where these women will have a bunch of KAs just around the lesion that was biopsied. And so I have to have this conversation, and then I will usually follow them out for, at least once, like every like 3 weeks until it's resolved, just to kind of pay close attention to it. What's your kind of go-to strategy for
Mm-hmm.
treating them?
No, I love that strategy. Yeah, same. I think it's really tempting to immediately say, "Oh, I missed something. It's recurrent," and we, go back and check slides on these things, and there's nothing. So yeah, I think just pausing before you go back and cut again, I think is
Mhm.
really critical
Yeah,
for these
absolutely.
cases.
Okay, our next one is utilizing box breathing to reduce stress and anxiety during Mohs surgery by first author Sophia Rossini and senior author Kira Minkus. So, patient anxiety and discomfort are common during Mohs surgery, particularly during local anesthesia administration. In this article, the authors discuss the use of box breathing, a structured breathing technique involving 4-second cycles of inhaling, holding, exhaling, and pausing as a simple tool to improve the patient experience. By activating the parasympathetic nervous system, controlled breathing may reduce stress, lower sympathetic activity, and improve pain tolerance. The authors report improved patient relaxation and cooperation when incorporating this technique during the Mohs procedure. I've heard of this box technique before, but never have incorporated it into surgery. What are your thoughts on it?
I love it. This kind of stuff, whether it's, I think there's a paper out of Penn, probably 10 years ago now, looking at things that you would assume would be helpful, like music in the rooms helps
Yeah.
patients for sure. It's nice to have like an evidence-based reason to tell patients, oh yeah, we should put some music on. Even sometimes they're like, oh, I like it quiet. I'm like, that's going to make all of us less nervous. It just brings the whole nervous vibe. I will sometimes, if I have really anxious patients, I'll sometimes box, or do some strategy of breathing, controlled breathing with them. I think it actually really helps. We have very few patients that we have to prescribe anxiolytics for. And I think early in my career, we had we could dispense ourselves, and then UNC, regulations made it harder and harder. So we just started prescribing it. There's a
Hmm.
pharmacy near our clinic. And now it's actually just, there's so many strategies, like including box breathing and other things. We'll have patients self tap while we're numbing. Sometimes actually helps tremendously. We tap with a Q-tip. Every single patient we tap with a cotton applicator while we're numbing, and it's similar to like the gating theory, basically.
Sure,
Yeah,
yeah.
I love this. This is a nice pearl for people to use.
Yeah.
It's really helpful to mitigate anxiety.
When you kind of join them to do the breathing, is that typically like before you do a level, before you do reconstruction, or just whenever they kind of feel like they're at their most anxious?
Yeah, all the above. Yeah, could happen anytime.
Yeah, no, I
If
think
you're
that,
about to do a difficult repair, some people, I think for me, most people are kind of past it at that point.
yeah.
They kind of, I think you maybe build up enough trust throughout the day that they're over that most anxious part of the day.
Hmm.
Uh, but yeah, usually it's in the morning when the uncertainty of not knowing what's coming next. I think it's before either the anesthesia or the first, usually it's the anesthesia the first time.
Yeah, absolutely. I think that I'll be using this tool as well.
Yeah.
Okay, our next one is bone wax assisted second intention healing. So, second intention healing is commonly used in dermatologic surgery, but traditional dressings may adhere to wounds, cause discomfort, and be difficult to use in irregular defects. In this article, the authors describe bone wax as a novel dressing option for second intention healing after Mohs surgery. Because bone wax is moldable, non adherent, and occlusive, it can conform to complex wounds, particularly those with exposed cartilage or bones, such as the ear, scalp, or nail unit. The authors highlight its ability to decrease painful dressing changes while maintaining a moist healing environment. Potential concerns include foreign body reaction and limited supporting evidence. Do you have any bone wax in your office, and how do you use it?
This is an interesting paper, and I think, yeah, we do have bone wax, and we use it for large, especially large scalp things where, the concern about air embolism is real in between layers, and so we just paste it on there if we've had to remove periosteum
Yep.
and the margin's still positive. I typically remove it before whatever we do, whether we're going to do the final bandage, we'll have the patient basically supine completely flat and then
Mhm.
bandage that way, whether we do a repair or it's going to be like guiding sutures or second intention,
Mhm.
um, or even a big repair. I've never left um, bone wax. And if you look through the literature from neurosurgery, orthopedic surgery, there's a lot of concern in leaving bone, because they mentioned briefly in the paper,
Foreign
like
body. Mhm.
osteogenesis is impaired by bone wax, and it just stays there forever. So yeah, you like you say, you get foreign body granulomas. There might be an increased infection risk. So I was interested they put on the phalanx because yeah, I would be concerned about what would happen. I think they're doing, changing out maybe weekly and refreshing the bone. So it's not staying permanently, but I would just put an asterisk on in my own mind, like, is it helpful? And when is it helpful? Maybe it is helpful sometimes, but be careful about leaving bone wax.
Yeah, no, I agree. I had kind of the same thoughts as you. It would make me a little bit nervous. It would be interesting if this group or someone else would do a study to see if it did improve kind of the wound healing. Right now, for those big scalp defects that I'm peeling off periosteum, I'm sewing in a Vaseline bolster just for a week, just to like kind of stimulate and keep it nice and moist. It would be nice if someone would do a paper to look at how quickly these wounds heal with the bone wax technique incorporated into it. Because I do think would be nice to kind of just put something there and tell patients they don't have to worry about it for a week. Because we've all heard about the complaining about the bandage changes. So I think something like that could be useful. But I would love to see some literature showing the advantage over it.
100%. I mean, that was the porcine xenograph was that 1 week we would sew it in those large scalp wounds, and it was, yeah, pretty cost effective. And
Yeah.
the other thing I'd say about, I love your Vaseline strategy, and I learned in preparing for this that petroleum actually has a 2016 study, and the allergy immunology literature showed that there is antimicrobial effect of just
Mhm.
petroleum jelly.
Yep.
So, and they studied in, atopic dermatitis patients. So I think I have seen very few wounds have trouble healing, even those huge scalp wounds just granulate in. And I think petroleum jelly, Vaseline works great,
Yep.
better than Aquaphor, better than, yeah, head to head bone wax. And maybe the other thought I had is bone wax for the forehead flat pedicle. Maybe we should wrap our
There
pedicle.
you
Maybe
go.
there's a 10th thing we can wrap around the forehead flap.
That would be interesting. All right. Okay, so our last one is 20-year history of cutaneous suprapubic growth in a patient with myelofibrosis. So this diagnostic case highlights the danger of assuming that a chronic lesion is benign. So a giant condyloma cuminatum or Buschke-Lowenstein tumor is a rare HPV-associated verrucous tumor with potential for malignant transformation. In this case report, the authors describe a patient with myelofibrosis who presented with a large suprapubic lesion that had been present for over 20 years. Initial small punch biopsies suggested a benign process, but given the concerning clinical features, repeat larger biopsy revealed squamous cell carcinoma in situ, arising within condyloma cuminatum, confirming the diagnosis of Buschke-Lowenstein tumor. What did you take away from this article?
Oh man, oh, those tumors are so bad, and
Yeah.
just, yeah, I think it just reminds me that anytime there's something large that people don't want to touch or deal with, it's like get a sample of it. I mean, I feel like in some ways this is kind of like the opposite of the eruptive KA, the migrating squamous atypia paper. It's like something that's there a long time. I think the flip side of that also is when do you treat this? How much,
Yeah.
because I think in the case report, they went on to have, surgery in the operating room and staged excision basically with the lesion to get it clear. And
Yep.
I'm sure it improved the patient's quality of life. So I'm not saying you shouldn't, but sometimes depending on patient situation, maybe it's better to not know what it is if someone's old enough that the disease is not going to be worth what they have to go through to get a cure. So
yeah, I absolutely agree with you. But I think, once patients land to us, I think that we have the clinical acumen to know if we, just always put your hat on, repeat biopsies if you need to, get second opinions, even if something's been there for a really long time, just get a second look at it.
for sure.
Yeah. Okay, well, that wraps up our Clinical Pearls episode. I want to just thank Dr. Merritt so much for joining us and sharing his expert insight. It was really wonderful talking with you and hearing all of your tips and expert insights. So thank you again.
You're welcome. Yes, really nice to be with you. And yeah, the great papers. Thanks for taking time together.
Awesome. All right. Thank you.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.